speaker, Patty Polina. Patty is a nurse practitioner who is nationally certified in family practice. She's also certified in advanced hospice and palliative nursing and has 20 years of experience in the areas of hospice and palliative care. She works for ATOP, the ATOP program, which stands for Admissions Transitions Optimization Program, which studies payment reform's impact on avoidable hospitalizations and long-term care. And she leads the Conversations Matters work group to promote advanced care planning. And she also serves on the board of Nevada COLS, the Providers Orders for Life-Sustaining Treatment. Patty, I turn it over to you.
Thank you. So I'm going to get right into the slides. I wanted to let you know I've been in hospice, worked in hospice and palliative care for close to 20 years. I started in the field as an RN, and I've worked in all aspects. I have also done palliative consults in the hospitals and some in the homes. I have done a lot of work in the field in homes. And anyway, we'll get started. Prognostication of heart failure is difficult because the possibility of sudden death exists throughout the disease trajectory. But many people live a very good quality of life for many years while symptoms are being managed and treatment modalities are effective. My fly fishing guide has a diagnosis of heart failure, and he seems to be doing quite well. And I managed to keep up with him. It is recommended, however, to plan for the day that the individual becomes too ill and may lose the capacity to make decisions when things change. Next slide, please. So the population suffering with heart failure, they tend to be older and they tend to have comorbid illnesses. In particular, diabetes is very common, COPD. They may have a history of high blood pressure, kidney issues, but these people do live longer because we have so many more things now. We have a lot more medications and how to use them, and implantable defibrillators, pacemakers. And then some patients, while they're waiting for a transplant, they may use ventricular assist devices. There are also IV medications, such as infusions, inotropic continuous infusions to support the heart while they may be waiting for a transplant, or they may just be not quite ready to bridge to hospice care. Next slide, please. So an important statistic to be aware of is that persons with advanced heart failure have a 33% chance of death or hospitalization within 1 year. And there are other statistics as well that for the general population, as we get older and become more ill, whatever our diagnoses, that we often lose the ability to make decisions just because we're so sick. And this may be temporary, it may not be. Next slide, please. So the American Heart Association recommends that everyone hospitalized for heart failure should be approached about an advance directive if they do not already have one. Now, my understanding is that our audience here may work in other areas like primary care, home health. So you would be seeing patients, well, hopefully before they're hospitalized, but maybe afterwards. and be talking about to them about their plans. So they may have just been diagnosed, they've had some tests done, they've been diagnosed with heart failure, and it's time for a conversation. And we actually will be providing a link to a wonderful advanced care planning tool in this presentation. And it has a number of great links to forums and also ways to have structured conversations. And that is very helpful, especially if you've not had those conversations very much before. It helps you to get comfortable with them and stay focused, because that's an important part of these end-of-life conversations. You're trying to get something done, but you can't hurry, and so you kind of need a structure. And you also need to know when to back off maybe and follow up, let the person digest what's happening with their health. So this may happen at a wellness visit, a follow-up visit. In long-term care, it might happen in a care conference. And in home health, it would happen on a provider visit or some kind of palliative care visit in the home. Next slide, please. So it's very important to record your healthcare preferences, and the primary place is in an advance directive, which is sometimes called a living will. And this advance directive also includes the choice of a durable power of attorney for healthcare. And that is something to be encouraged. Even if a patient says, you know, my mom's taking care of everything for me, or my sister, it's good to get those roles straightened out if possible. Also, a patient may have many children, and even though all the children should be involved, it would be less stressful for everyone if they do choose a durable power of attorney to speak for them. And also, choosing a DPOA for healthcare can assure that that patient's wishes are followed and in a timely manner. And I will repeat this, just because you have an advance directive, of course you may choose either way. You may want to continue all aggressive therapies, but say if you do not, emergency services will still, at least in Nevada, will still resuscitate you even if you have an advance directive. What it helps is if something happens and then you have somebody to speak for you when you cannot speak anymore. And I may repeat that again in another way, and if there are any questions, we can talk about that. Next slide, please. One very useful guide, there's several guides, but one very good one is the Conversation Project, and they even have some nifty videos and things. It touches on who would make a good candidate for a DPOA and how to talk to that person. And so emphasis is on choosing someone who knows your preferences and that they will stick to honoring them, even if they may not feel the same way about their own choices. And also, you want to tell your family members who your DPOA is ahead of time rather than waiting. Pardon me, I'm just making sure I mentioned everything I needed to on that. It's also important that the forms are accessible to everyone. And some states have lock boxes or repositories for these. But it's good to make sure that everybody involved has a copy of the advance directive. and including the physician's office, the home care agency, the long-term care. So there will never be hard to get a hold of. That's very important. And one thing that I was going to mention on the previous slide, and can we back up one slide, please? Sorry, thank you. One thing I wanted to mention about recording your healthcare preferences also too, is it's important to explain to the patient what happens during resuscitation in layman's terms, because many people have seen it done on television, and what they don't realize is that it does not work as often as it does on television, and also that person may not be the same after they're resuscitated, depending on their current state of health and how many illnesses they have. So explain that a person would be having CPR, which would be, you know, pounding on the chest or massaging the chest, however you want to express it, and then intubation, and then being put on a machine that helps them breathe. It's important that they know those things. Many people are very surprised when they say that I don't want my relative on life support, and they've been on a vent for a couple weeks. That has really happened to me. Anyway, so could you advance the slide, please? Make sure that I covered everything there. Next slide, please. So the goal of treatment for symptoms of heart failure is actually to continue all the medications that they're on and continue curative therapies until there's a resolution, transplant, or the therapies stop working. And the American College of Cardiology recommends that palliative care be offered for heart failure refractory to most treatments, and in tandem with transplant, investigational studies, and left ventricular assist devices. I could have realized that this is mostly primary care. Depending on the state you live in, there are community palliative services, but it's not as readily available as palliative care in the hospitals. I'm hoping that it will be more so. They also recommend that palliative care be offered more in long-term care, but I know currently that it just doesn't exist everywhere right now. We haven't caught up with that need. Next slide, please. But the philosophy of palliative care is actually similar to hospice care. It's part of hospice care, actually, because it attends to all the whole person, the physical, the functional, psychological, practical, and spiritual consequences of a serious illness. And that goes as well for hospice care. And palliative care itself is appropriate at any stage, and it can be provided along with treatment of curative or life-prolonging intent. So if you do live in a community where palliative care services are available, they are actually very helpful. I've gotten very good feedback from people who have received palliative care in the community in various places. However, we haven't quite caught up with the need in palliative care, I'm sorry to say. Hopefully that will change. Next slide, please. So hospice care is appropriate when a patient is not a candidate for therapies such as transplant or ventricular assist device, and therapies like inotropic infusions are no longer controlling symptoms, or if, for instance, the patient has been just declining these therapies. They've decided they've been through enough, and they made a decision. Next slide, please. And I'm sorry, could you back up to the previous slide? Okay, one thing I did want to mention that's important as well is that in hospice, we continue cardiac medications because those actually provide comfort. So you're going to provide as many of, if they're still on cardiac medications and they're working, hospices are continuing those medications. And also the symptoms that people have in heart failure, such as shortness of breath is very common, chest pain, loss of appetite, edema is big. So these are different things that hospices may address. Although with loss of appetite, what they may do is just loosen up the cardiac diet and just let them eat what they want. That's probably the most practical thing for a hospice patient, as long as it's not causing them more symptom problems. Thank you. Next slide, please. Persons with advanced illness and limited prognosis may choose to work with their healthcare provider to create a medical order regarding end-of-life treatments. And this would be a very good thing to address in primary care rather than waiting for a crisis, although it is not for everybody. We use a surprise question, which is, we would not be surprised if this person died within a year. These are the people that are more appropriate for a POLST. And another person appropriate for a POLST would be somebody with early Alzheimer's disease or early dementia, but they still have capacity for decision making. These persons in particular may benefit from making out a POLST document, but it is a medical order. So it doesn't substitute for an advance directive and designation of DPOA. We really encourage people to do that, and the POLST is something that builds on it. But neither one really does substitute for the other. They're somewhat different things. And I can answer any questions on that you might have. Next slide, please. So this is has a link to our online resources, and it really is very good. It was created for our by our Comagin team, Health Insight, now Comagin, and it's a tool that's designed for primary care offices, but it could be used by anyone that wants to have these conversations because it has so many forms and tools available. And it goes through implementing advanced care planning in your practice, and it goes through steps and roles for the whole office staff, different office staff. And it also talks about follow-up and coding and billing. So that's particularly important, specifically Medicare billing for well visits. And it has a very good tool on having structured serious people with serious illnesses, conversations with them. It has a very good structured tool for that. And one other tool I'm going to mention, or maybe I'll wait for questions to mention that one, another structured tool. Next slide, please. So to summarize, the trajectory or course of heart failure can be vary greatly, and it's good to plan for the possibility of incapacity, even though that incapacity may be temporary. And of course, when that person regains, if the person regains capacity, then of course the DPOA steps aside. Where available, palliative care is compatible with all curative therapies. And then hospice care is for advanced disease, but many of the same medications are continued for palliation of symptoms, and plus a few are added, like possibly morphine for shortness of breath, maybe additional breathing treatments, oxygen therapy, whatever it takes to keep that patient comfortable in hospice care. I have some organizations I was going to mention also, and many of you may be familiar with them. American Association of Hospice and Palliative Medicine is a great resource for physicians and for nurses and nurse practitioners. Hospice and Palliative Nurses Association has great resources, and both of these have good journals too that are included in membership, so it's very worthwhile. National Hospice and Palliative Care Organization has great resources as well. And there's a blog that's free called Pallimed, PALLIMED.org, and it's free and it's got great articles. It's really useful. And then there's also CAPC, which is a Center to Advance Palliative Care, and that's another great organization. But these are all memberships. Pallimed is free. HPNA is actually, you get a lot for your money. So those are something to look into. So that concludes my my slides. So I'm ready if there are any questions.
Thank you, Patty. Thank you so much for your presentation. So we're opening it up for questions, and we'll do our best to answer as many questions within the remaining time frame. If we don't get to your questions by the end of the webinar, please be assured that we will answer it in an email when we include the presentation and the recording link. Rebecca, do we have any questions from our audience? Okay, so Patty, what is, and I'll give some time for people to ask any questions, but what is the best way to approach this subject with patients? This could be a sensitive subject for some, I imagine. Might take some finesse. So do you have any tips for having that conversation? How would you begin?
Well, it's important to normalize the conversations, for instance, in a physician's visit, and also too in our advanced care planning tool, we actually suggest that a letter is sent ahead of time if you know you're going to have that conversation, if that's like a well visit and you're planning to have it. We have an example of a letter you can send, so it's not like it's not a big surprise. It's also important that that person be comfortable, depending on their family structure, you would want to see if they want any other families available. But first of all, it's important to reassure them that this is a conversation that we have with most of our patients, because an advance directive is actually good for any adult. And certainly if they've been diagnosed for heart failure, they know they have it, that they can also be told that, you may have some time. This doesn't mean you can't have a good quality of life. You may need to make some adjustments, but it's also good to plan for the future. It's also important to recognize if there's any cultural issues that you need to ask about. We have a very diverse population in Las Vegas, and you sometimes what you need to find out is, does that patient make their own decisions? It's a little tricky how to navigate that. They do, but some patients will prefer not to know everything, and they want their older son to know because of their culture. And so you have to really clarify what's going on there and tread very carefully, because you do have to make sure the patient is informed as much as they want to. And one of the things involved in that is a technique called ask, tell, ask. What do you know, and what do you want to know? and then you give information, and then you repeat it. You know, what else do you want to know? And you give information. And so that's one way of navigating.
And you mentioned another resource. Can you tell us what that is as well?
Yes, it's a technique of conversation. Now, this works with conversations that are maybe for a person who's really hospice appropriate, but it could also be for someone who just with a serious illness that isn't quite ready for hospice. It's called Spikes, and it's actually well known in the palliative and hospice field, and social workers, I think, are mostly familiar with it. S is for setup, listening skills, sit down if you can. Sometimes it's hard to find a place to sit. P is perception, open-ended questions to get the patient and family viewpoint. And then you kind of build on that. I is invitation. What do you want to know? Because if you force information on people, they're going to close down. So you want to see, you need to know what they're ready to hear. Knowledge, give information in lay language. Don't talk too fast. Make sure they can hear you. E is empathy. Acknowledge this is a difficult time. You know, allow for tears. If they're, you know, if they're upset, let them, you know, hand them a tissue. S, summarize the conversation. Where are we at now? And assess readiness for next steps, because there may need to be another conversation.
And talking about heart failure, do you have any tips with possibly patients with that have hypertension issues before they are diagnosed with heart failure? Maybe even explaining the risk of developing heart failure if you have any uncontrolled hypertension? Yes,
and also kidney problems and stroke. So all of those things. All of these conversations can be used with any serious illness, really. Even with cancer, we use some of the same types of skills. It's just a different diagnosis. So yeah, hypertension goes hand in hand with heart failure, because they do have many other risk factors. And also too, to normalize that conversation, depending where that person is at, we encourage, actually, when people reach adulthood, we encourage people to have an advance directive. I know many people don't, but it's not unreasonable to put it that way. And then we tell people to review that every 10 years, or if there's a major life event, marriage, divorce, having children, retiring, you know, losing a job, you know, whatever. So you can certainly normalize that conversation.
Okay, thank you so much, Patty. So we went a little over our time. So thank you for those of you that have continued to stay with us. So again, thank you again for joining us. If you have any other further questions or have about end-of-life planning or the cardiac work, please contact your state leads. And we would love it if you would answer a short survey regarding today's webinar. That would be really a benefit for us. And our next monthly webinar will be on June 19th, and we will be discussing the 5-year journey of the cardiac work, the impact we've made, and what you can expect from CoMagin in the next scope of work. So please mark your calendars and look for an invitation soon. And again, thank you so much for attending, and have a wonderful rest of the day.